folks on the call? All right. Hearing no questions, I'm going to keep pushing on for us here. So redefining medication safety. So what's the problem? And the problem, as many of you know, is unfortunately the traditional one-to-one drug analysis that we currently have. And as you see, there's a perfect screenshot of what we're doing now. It's just not working. It's unfortunately, it's looking from one drug to another, and it's out of date. It's 4 decades old. It's embedded in EHRs, pharmacies, PBMs, et cetera. Whereas when you look over to the right, MedWise, what we do is we're looking at patients in a combined manner, and we're looking at all the medications in the aggregate. We're looking at all pharmacists, all providers, and we're looking at this individualized medication decision support. So it's a great opportunity. And it's a great differentiating tool. So the reason we're in the problem is because of the one-to-one drug analysis. The way we fix it is by having this aggregate, kind of like we call it a bicycle wheel, where you're looking at all the meds and then you're sort of bringing them all into the middle as one ingredient, or all the ingredients together. And that's how you can see that there. So whereas you can see here, this is the Lexi alert system for the same patient versus the MedWise matrix. So you can see how the issues come in, and we're going to dive into this a little bit, deeper. So if a pharmacist was, looking at this Lexi alert system, they would see 21 PDF generated issues that had to go and open. And many of you on this call have probably seen this. Whereas in our matrix, you're going to have reds, yellows, and greens. And we're going to specifically say, hey, here's the issue. It's because of this medication. And it's a matrix that's going to literally show you which meds line up with the other meds and where the issues are coming in specifically. So this risk score that our product brings out it's a new paradigm. This is where, again, we go back to the colors, and we see here that, obviously red is severe, orange is high, yellow is intermediate, low, minimal. And unfortunately, we see a lot of reds, yellows, and oranges. We see a lot of those out there as we risk stratify different populations. What we would propose to do for your Medicaid, if they would like, or others, would be to risk stratify their entire population and then figure out which ones could benefit from looking at this. So great opportunities here. We use pharmacokinetic and pharmacodynamic characteristics of the identified active ingredients that feeds our algorithms that compute our medication risk score. So most pharmacists are really excited by this science and really feel empowered to be able to do this. And again, if we go to Kentucky Medicaid, they think this is a great program. This would give them an opportunity to push this down to community pharmacies, various pharmacy, however, we work that out. And then the pharmacist would basically look at these risk scores in the various patients and then adjust medications and work with the patient. Sometimes it's just time of day. Sometimes it's as simple as changing the time of day of when the medications are taken versus, sometimes it needs to be a change in regimen. So I talked about stratifying. So what we're going to do here is we're going to stratify the population. As you can see here, it varies. Some populations have a higher risk, some have lower risk. It just depends on that. And you can see here at the bottom, there's a correlation between how many patients and how severe it is. And the thing that we like to say, and where we think pharmacists can be the most empowered and where it can be the most beneficial to Medicaid is, we look at those greens and yellows and oranges, and we're trying to stop those from becoming reds or, whatever other color moving up. But essentially, our methodology and our technology will identify those patients and will help with that early on in the process. So questions about this before we keep going? This is going to show you how we save money based on the risk score, but questions, comments at this point? And I know Brian, unfortunately, is having some trouble with his audio. Mindy, are you on the line and would like to add in this to this?
I just got a real simple question, Eugene. Have you all got an alternative way of scoring for those people, those pharmacists who are colorblind?
I'm sure that we do. I'll be honest, I'm not on the technology side, but that's a great point. I believe we have the number system. So obviously the colors just kind of like it just helps to go along with that. But yeah, I can get back to you on that and answer exactly what it is. But my initial thought would be that it's just the number score, and those numbers correlate with the various colors. But great point, and we definitely want to make sure that our product is usable with everybody. Other questions or comments about this? Questions about the science? Questions about the issue of adverse drug events? Does everybody think that we're currently trying to address adverse drug events? I know we have a lot on our mind, but just curious what folks think about adverse drug events.
Eugene, this is
Go ahead.
Eugene, this is Fatima. I'm the interim pharmacy director at DMS. Can you go back a couple of slides?
Yes, absolutely. What slide were you looking at in general?
This one. I apologize if you mentioned this. So the MedWise risk score, how are each of these defined? The minimal, low.
Yeah, and actually, I see Mindy Smith is on the line here. She's actually one of our pharmacists, and she's our vice president of professional affairs. So I'm going to let her answer that. I'm actually not a pharmacist, but I've been around pharmacy for quite some time. Mindy, do you want to chime in on how we define the various levels of risk score and kind of go from there? I spoke too soon. Maybe she's not on. Let's table that question until she comes on. As I said, she's one of our pharmacists, and she could help answer that question. But essentially, I think it might be on the slide before, and I know we just changed our levels. But
I'm here. Can you hear me now?
I can't. We can. Mindy,
Okay.
did you hear the question? They were just curious
I
about
did.
what. Yeah, perfect.
Yeah. So I apologize for being late. I had a little family emergency here, and we just got home. That related to the risk score, the way it's calculated is that through our science and our research institute has essentially assigned a weighted value to every single oral medication that is available on the market, including herbal supplements, even CBD is in there. And the weighted value has to do with their attribution to the 5 risk factors. And Eugene, I don't know if you've gotten into the 5 risk factors yet, but I can go into that more in depth. But essentially, those 5 risk factors is how we calculate, and we do a risk score on a scale from 0 to 50 numerically based on those weighted values. So, for example, a metoprolol may have a sedation weighted value of a number 1, but a hydrocodone would have a weighted value of a 3 being the highest. And that we logarithmically calculate that value, and it's been actually that graph that Eugene displayed with the risk score correlation of 20 or higher, where medical spend actually doubled, is attributed to over 13 million patients, where we've risk stratified using the risk score based on the patient's medication and its correlation to those 5 risk factors that cause adverse drug events. Does that answer your question?
Yes, it does. Thank you.
You're welcome. Eugene, I'm happy to jump in and keep going.
Yeah,
I know
yeah, absolutely.
we have limited time. All right. And did you cover this slide already?
We just were getting into this. We
Okay.
were just getting into how we can reduce, medical spend, and that whole cutoff point of, score of either 15 to 20. That big kind of drop off. We were literally just getting into it. So if you want to take it from here, I can just push the slides.
Excellent. Okay. Yeah. So as I mentioned, so we've identified, so a risk score of 20 correlates to the highest risk score. And we have identified, looking at thousands of medical claims data and the correlation of the risk score and patients' medication they're taking, their medical spend actually doubles when the patient has a risk score and it exponentially goes up, their medical spend, the higher the risk score is. And I have some more data we can show you in a few future slides. Go ahead. So to talk about those 5 risk factors, the MedWise science is based on solely looking at and risk stratifying, as I mentioned, using and looking at a patient's medication that they're taking, including, as I said, during the MedRec process, you can add herbal supplements, OTCs, and other medications that they're taking over the counter. We pull in 5 key components. We look at the FDA Adverse Event Risk Reporting System information, that we pull in the FAERS information, and we identify those reported side effects from that system that correlate with the patient's medication regimen they're taking. We also look at anticholinergic burden and sedative burden, and we weight that cumulative value according to those key risk factors of anticholinergic side effects, as displayed on the right side of the screen, where everything is drying and can cause falls, in addition to sedative burden. We also look at long QT syndrome for obvious reasons. And then one of our differentiators is competitive inhibition. So if you go to the next slide, because we all are aware that medications 80% of medications are metabolized through the liver, through our cytochrome P450 liver system. What we've been able to do essentially, and I'm going to show you some examples, is we have been able to map looking at that individual patient medication regimen. We map every single metabolic pathway, all of the cytochrome P450 liver enzymes that the medications go through. And we also tell the pharmacist which medication has the highest affinity to that liver enzyme, so that if it has a higher affinity, like in the example of a car in a parking lot where paroxetine has a higher affinity to 2D6 over oxycodone, paroxetine gets the spot. In fact, it's an inhibitor. And so oxycodone has no way to get into that parking spot. Oxycodone and there's 4 key opioids actually that are prodrugs for 2D6 and need to be 2D6 to actually even become activated into their active metabolite. So this patient not only is getting the toxicity built up from those side effects, but also is lacking pain control because oxycodone can't be converted, or the opioid can't be converted into its active metabolite for pain. So the next screen. So this is the next 2 slides I'm going to show you are the screenshots of the actual MedWise science system. This is what the pharmacist sees and is displayed. So on the individual level, as this patient, Edward Orange, the pharmacist completes a full MedRec, adds in additional information that may not be captured in their pharmacy management system through that process. And then the bullseye on the right, you can see, has the 5 risk factors that go around the bullseye. This gives the pharmacist an immediate visual of where they need to focus. So anything in the red zone around that red ring is the danger zone. And my goal is to not only pull that risk score down through changes in medication therapy, maybe change in time of day, or it could be deprescribing, or it could be changing into a different drug class, or it could be even when recommended by the CDC, adding pharmacogenomic information to the profile. I can see immediately here, this patient has an issue with anticholinergic burden and some issues with competitive inhibition. On the right side of the screen is the FDA adverse event risk score information. And this gives me that immediate snapshot of those side effects that the patient may be suffering from, that are all attributed specifically to that patient's medication regimen. If you go to the next slide, This is a screenshot of the matrix. So as I mentioned, we map the patient's medication they're taking, and we map every single cytochrome P450 and non-CYP pathways across the right side of the screen. So as you can see, it starts with CYP 451A2, goes to the non-CYP interactions, and think of it as an accordion. It will expand and contract based on the patient's medication regimen. So we map all of those medications that they're on. So as you can see on the left-hand side of the screen, we have the list of medications. The second column, we have the bioavailability of those medications. We have the third column is the renal clearance of the medication. So the pharmacist has that information on dose toxicity, where there may be, we need to just decrease the dose because of the interaction, the competitive inhibition interaction. The fourth column is the ACB, is the anticholinergic burden. So here you can see this patient, you can see paroxetine has the highest of a scale from 1 to 3 of an anticholinergic side effect. We roll that information number up to the top. Same with sedative burden. So I can see here my patient is on several medications that can cause drowsiness. And then I'm going to go over and look at the column. So you look down, the pharmacist, of course, is taught how to read the matrix. And there's a key that is there for you as well. But if I look at 2D6, let's look at 2D6 column. I now have immediately at my fingertips for the first time ever, from a AI perspective, as a pharmacist, I can go, oh my goodness, I've got paroxetine, that's an inhibitor of 2D6. 80% of metoprolol is metabolized by 2D6. Paroxetine is blocking metoprolol from being metabolized. So I have a significant issue of toxicity going on with metoprolol. In addition, 25% of trazodone is relying on 2D6. So now I've got a buildup of trazodone in the system because of the paroxetine blocking that. And in addition, the codeine being a prodrug for 2D6, 10% of that medication is reliant on 2D6 to be activated into its active metabolite. Paroxetine is preventing that. So sometimes what we see is that there could be even an unintentional overdose that occurs with these 2D6 opioids, because the patient may go back and say, hey, I need more pain, I'm still in pain. The physician, increases the dose in that scenario, and the patient stops taking paroxetine in a couple of days for whatever reason they forgot. Maybe they quote unquote feel better. And then that opens up the floodgate for all of these medications to go into 2D6 if you remove that paroxetine, and can cause an unintentional overdose in the case of an opioid. So I think I have one more case study just to show you one thing that we don't do. If you go to the next slide, keep going one more, because I hit the opioids. This example is to show how this patient's only on 4 medications. So we actually don't look at number of medications for this very reason. This patient's on these 4 medications. There are issues with competitive inhibition, with sedation, and then this patient also has pain in their knee. So if you look at the matrix, the bupropion is the strongest. The darker the color is the highest affinity. It's actually preventing the duloxetine from metabolizing, as well as the trazodone. So in this case, after working with the physician, recommendations are to discontinue the bupropion because of the competitive inhibition of the duloxetine and the trazodone, monitor for excess sedation with the trazodone, and then you can replace the ibuprofen with the glycophenate gel. But just doing those simple changes reduce the risk score of this patient from 23 to 14. And it puts that patient out of the danger zone. And it gives the pharmacist this amazing information right at their fingertips. So before I move forward, because we have some great outcomes data, and then I wanted to talk to you about using the MedWise science as the core of what we've done in the CMS Innovation Project that now has been replicated in New Jersey, in the New Jersey Medicaid, and they just passed legislation. And we wanted to talk with you about consideration of bringing a program forward in the state of Kentucky for state Medicaid that leverages the pharmacist's expertise as a medication expert, pays them for their expertise, and this allows pharmacists to impact total cost of care by leveraging our expertise in a way that's by using information and giving you information at your fingertips that's never been available in this manner before. So before I move forward, are there questions about the matrix that I can answer? Or Ron, I don't know if you have any comments.
Just for my understanding, and this is Fatima again, is this program for the point of sale pharmacist, or where exactly is it being implemented?
Great question. So Eugene, if you go to the next slide, I think I have the screen on the Enhanced MTM program.
Yeah, and one thing
will give you a great example. Go ahead.
One thing while we're bringing that up, you just want to make sure Fatima, this and to Ron and everybody else on this call, this is going to really allow patients to better utilize that valued relationship with their pharmacist. That's our goal with MedWise. And then from a Medicaid perspective, we are going to guarantee these outcomes and cost savings. And then, bottom line, in no way is this ever going to take any patients out of the pharmacies. If anything, it might actually tie them more closely to the pharmacies. So for those of you on the call that are community pharmacists, this is going to really make a big difference, we hope, and what we've seen so far and what Mindy's about to show here on the Enhanced MTM slide. But this can be used, in the community setting. And again, it's just going to really utilize and better, grow that relationship with their pharmacist. And then we're going to guarantee those savings that the pharmacists are going to bring you, to Medicaid. So we're going to, kind of go from that side of it. But one example of what we've already done is our EMTM program.
Eugene, how do you see this fitting into the community pharmacy workflow? Is it going to be, just you're going to treat it as an MTM that pops up and, hey, you've got somebody here to work up? Does it alert you as you're filling prescriptions to where you can go ahead and schedule that, or so I guess that'll help out.
I'll let Mindy take that. She's one of our pharmacists.
Yeah, and so Ron, right now we have integration of the risk score in the Prescribed Wellness software system as well as Pioneer RX. We haven't, there's Prescribed Wellness, for example, interfaces with 55 pharmacy management systems. There's a lot of PMS systems out there. In the perfect world, we'd love to have that integration, but at minimum, to your question, we would be able to alert you in a way as a participant in the program, whether it be in the MedWise system as a single sign-on, or through, if you have integration platforms that exist today through Prescribed Wellness or Pioneer, so you could see that list. But we would have an ongoing way to make sure the pharmacist who wants to participate in the program would have that attribution list of those Medicaid patients, where we're also continuously looking at the risk score, right? So it's an ongoing, it's not a one-time risk score analysis. For example, Prescribed Wellness and Pioneer pharmacies today, if they're Medicaid, they fill a new prescription, the risk score will change according to that prescription fill. So they can actually see the change in risk score, and it alerts the pharmacist in that manner that the patient needs a med safety review, so they can go further. So a great example, and I think, those types of details we would love to put you in touch with. We have so in Region 25, we're in the 5th year of this 5-year project with the CMS Innovation Center, of which CMS incentivized for the first time a standalone Part D plan to actually achieve savings and medical reduction in Medicare Part A and B. So we're part of Region 25, where we have over 400 community pharmacies in that 7-state region, participating within and conducting med safety reviews, of which we identify through the health plan's claims data from Blue Cross Blue Shield. And if you go to the next slide, Eugene, we could actually put you in touch with Ron, some of those pharmacists who have been participating for now, I think, 4 years in the program. In year 2, that's when we did the ramp up for the community pharmacists to engage. And we do have a backup call center, so we could work with you in Kentucky to have some sort of, you could use, your resident community pharmacist. We could work with university or school pharmacies. We could have a Kentucky backup call center too, to make sure that if for whatever reason that community pharmacist can't conduct the med safety review at that time, that referral could go to a Kentucky-based pharmacist wherever they are. We could set up a network that way that works for all of you. But I wanted to show you too that in those patients that we intervened and conducted med safety reviews, which is about 20% of the population in a Medicare population, are at high risk. We've calculated a net savings of $129 million. And that's what really got the attention of the New Jersey state legislator, who was chair of the health committee, who went, okay, if you can achieve reduction in Medicare patients, why can't we apply the same model to Medicaid patients? And so, Eugene, I think on the next slide, I have the New Jersey legislation. Oh, I have more.
I can get you there. While we're jumping through the slides to get over to that, Fatina, did that answer your question about how the product or how this comes together?
Kind of. I think I'm a little lost in terms of, what this would look like on the community pharmacist end, and how exactly Medicaid comes into play.
Yeah, and Fatima, maybe could you tell us more about your role at the department? Sorry, I mean, and obviously we're all doing the best we can to meet virtually and instead of in person, but maybe you could kind of fill us in on more of that side of it. And we've heard nothing but great things about you, but just curious so we can kind of tailor our answers.
Yeah, sure. So I'm the interim pharmacy director, and my day-to-day is, really helping pharmacists and, the providing oversight for our PBMs, working closely with pharmacists, identifying issues around reimbursement, and just overall oversight of the pharmacy side of the Medicaid program.
Oh, great. That's wonderful. So yeah, I mean, to answer your question, I'll take the first step and then Mindy or Mindy, you there?
Eugene, if you go to slide 33, I think
33
this may help.
Awesome.
Fatina answer her question. It's a workflow slide. So Fatina, currently today with the enhanced MTM program, where we have those 400 community pharmacists, but you could set it up so that any pharmacist who has if it's ambulatory care, if it's in a medical office, or with community pharmacy, however you want to set up the network of pharmacists, they could have access to the URL for the MedWise Science. And we essentially would receive, so number one, we would receive pharmacy claims data from the state from Medicaid patients. We would risk stratify all of those. So we do a analysis on all of your Medicaid patients to identify which patients, and we would set eligibility requirements. I don't know if you would want to exclude Medicare or how you would want to set it up. That's, that's for further discussion. But we would take that target cohort of Medicaid patients and risk stratify them, identify all members at high risk. Then in number 4, the pharmacists, we'd have the attribution list and push those to the pharmacy network. So the pharmacists participating in the program would conduct a med rec. Number 5, they conduct a med safety review with the MedWise Science using the matrix. It's the core of what we drove the outcomes that we saw in the enhanced MTM program that we can go back and look at. And then those interventions are communicated. The pharmacist works significantly with the patient to identify, okay, making sure the patient understands recommendations and changes or not, and make sure there's concordance with the patient on recommendations and changes of therapy or deprescribing. We work with physicians as well, and then those outcomes are documented. You see at the bottom, the enhanced MTM, in the enhanced MTM CMS model, the pharmacists participating receive $175 for a med safety review, and then they can conduct a secondary follow-up med safety review, of which they receive $125 for that review. That's per patient per year. You could set it up also in some sort of value-based payment model. I think Iowa has some creative ways where they're doing PMPM. So, those can be tailored to the state and how you would want to set it up. So does that answer your question a little bit from a workflow perspective?
So to make sure I understand correctly, you all would need the state to provide pharmacy claims data, and then you risk stratify, identify the highest risk for an ADR or an ADE rather. And then who is conducting the MedRecs, the dispensing pharmacist?
Yes, the pharmacist who will be conducting the med safety review, or they could have even a pharmacist trained to gather that information, or if the patient brings in all of their, sit down and do a brown bag, there's different ways you can conduct that, or even over the phone if the patient is remote.
Okay. And then
Hey, Mindy, this has been from KPHA, just to kind of clarify, because I've heard Dr. Ali ask the question a couple of times. So, and I've worked with these folks in the past, and the answer to that question is that it would be the patient's community pharmacist, as long as they are trained in MedWise and they are a provider, then they would be providing it directly to their patient.
Correct. Thanks.
And we do the training, we'll work with KPHA on that side of training, or if Medicaid wants to do, direct it a different way. But, as Mindy on this call, who's a pharmacist, she's one of our certified MedWise pharmacists. So that's what we did in the MTM model. And it's a very, doable process. But we think that Kentucky is well positioned. You have some fine universities there. I was at your meeting and got to see a lot of what's going on, a lot of the energies between your associations, your university, your Medicaid. You've got a lot of great things going on. And we think this product and this program would do very, very well to reduce, adverse drug events in your state. We want to be respectful of time. We have other slides we'd be happy to share with you. We can do other calls if needed. We'd love to continue to have this conversation, but we also want to be respectful of time. And
Eugene, I just want you to bottom line your ask and tell me if I'm wrong. What you would like for this committee is to vote to recommend this program to be considered at the next Medicaid Advisory Council meeting, recommended to CMS to be considered for either any kind of format to get this started, whether we want to do a pilot study, whether we want to do a full-blown program. You all have the statistics to show that, you all have guaranteed savings on this program where it's working elsewhere. From what I gather, it can either, depending on your interface with your software system, your pharmacy system, it can identify patients as you're filling prescriptions that you can go ahead and pinpoint that person and maybe set up an appointment, or you can work just the MedWise program outside of your pharmacy system that'll go ahead and identify those patients and you can set up appointments. So if I said anything that's incorrect or need to add anything there?
No, you said it perfectly, and we that's exactly what we would like to do. And we would like to, can't say it better ourselves.
Okay. Do we have any further questions by anybody on the call? I know we have 6 out of 7 of our members on the call here. So does anybody have any further questions?
Ron, this is Rosemary. I think my question would be, who would be, what would be the cost? I represent KIPA, the independent pharmacist in the state. What would be the, to be part of this network? What would it cost? What would be the cost to the community pharmacies? And then who would be paying for these EMTMs? And what would be the cost to the Medicaid department, to our department that we're working closely with?
Those are great questions,
Okay.
Rosemary. We would work with you in the state to, as far as a budget allocation, so that there is technology. The technology access is part of the program from a fiscal perspective, as well as payment to the pharmacist for those clinical services. So our goal is to, in the program, the state is paying pharmacists for med safety reviews. They are impacting total cost of care. And because of our evidence and program analysis, we'd also work with the state on target population and the analysis of what we could estimate based on our experience of what we would produce as far as a return on investment, so that the state is also receiving and reaping benefits of impacting total cost of care by leveraging the pharmacist's expertise from a clinical MTM perspective.
And
So all of those are, I don't have specifics, but it's more about working with the state on what those costs are, how many patients we estimate, what are the target patients, and what gets bundled in from a fiscal note, which is why I mentioned the New Jersey legislation. They actually legislated so that they could allocate a budget that was tied. So a fiscal note is tied to the New Jersey legislation, which funds the program for the state Medicaid. So it just depends on in Kentucky if the state has funding available, or if there is a way to fund a pilot, as Ron mentioned, or would it be beneficial to go to the state legislature and put this into legislation as a program to get funded, so that pharmacists, so there's a fiscal note and budget allocated to pay the pharmacists for the services.
And bottom line, 2 points to that to add. Number one, we would guarantee the savings and we could work with you on that. Number two, to Medicaid, as far as costs for pharmacists or Medicaid or how all this works out. Unfortunately, polypharmacy's created quite the issue out there, and there's millions of dollars to be saved. So, we have a real opportunity here for our community pharmacies in Kentucky to make a difference for their patients with that valued relationship and use our technology. But we're not here to create burdens for the pharmacists. We're not here to create burdens for Medicaid. We're, if anything, trying to solve the problem of adverse drug events. As far as the nuts and bolts, a lot of your pharmacists probably already have some of our technology. We'd have to train them on this new part. But we anticipate this would be a pretty seamless process for the community pharmacies to participate in.
Well, let me break this down to see if this makes sense. So basically, which has been all along, your statistics and your slides are showing that, the state, regardless of the amount of money that's allocated for this program, you're going to be able to show, or what, programs that are currently ongoing where they're going to get a return on that investment that's going to be far better than the costs that they pay out. That's taken care of the state side. As far as, or the payer side, as far as the subscription cost to any network pharmacy, is there any cost there?
As far as the cost of the pharmacist, I mean, as we work with the state and kind of, you know, look at the varying side, and I'm actually trying to find our outcomes slide, but you know, as far as cost to the pharmacist, I don't anticipate that there would be a cost to it. I guess it just depends on how the state were to put this program together. Mindy, do you want to chime in on that side of it? I don't think there's going to be necessarily a cost to the pharmacist ultimately. I mean,
our goal is to bring MedWise and get it in the hands of pharmacists, and we would work out a way so that the access to the technology is funded.
And then to bottom line from the patient side, there is no cost to the patient. They're just getting the benefit of being
That's
better
correct.
quality of life and less hospitalizations, less ER visits, all that good stuff.
yeah, and bottom line,
That's correct.
if a pharmacist wanted to buy our tool and wasn't going to, you know, just was going to do this for a cash basis, which we do have pharmacists around the country that do that, there is a cost to the tool, but anticipating that Medicaid would be kind of driving this as we help Medicaid reduce adverse drug events and reduce cost. Obviously that would be kind of factored into this. So there is a rack rate, if you will, but this is going to help on that side of things there.
Yeah.
So
If a pharmacist wants, prescribed wellness pharmacies can access MedWise today for $199 a month. That's the fee for if they want, they can use the tool today, and have the MedWise.
Is that in addition to
sandbox
the
all
prescribed
the
wellness? I'm sorry, is that in addition to the prescribed wellness charge?
That is if they are a current prescribed wellness pharmacy. And if they're not, they would pay for an additional data flow because we risk stratify the patients through their claims data on a 24-hour basis. So there's an additional fee on that. But through our relationship with KPHA, all members receive a 20% discount that $199 reflects.
Okay. So you anticipate that would be the fee for participating pharmacies with this program, unless there was some legislative effort to fund some things. Is that correct?
Mm-hmm.
Okay.
Correct. Yes. Yeah. Because to me, it's a part of an administrative cost, and so if there is a way to work with the state to allocate that within the budget, then then the access is available, and then you get all pharmacists have access to this going forward, which is also really, really great for patient care in Kentucky for all patients.
We don't anticipate that pharmacists are going to have this, you know, burden of costs without an actual program in place. You know, Mindy and I both, and I think I mentioned earlier on the call that we both used to be, you know, executive directors of our state pharmacy associations, much like I've been, and you're like yourself. We know the burdens of pharmacists. They're already paying lots of, you know, dollars for various programs that they're required to have. So that's not the goal of this. We would anticipate in working with Medicaid, you know, that the costs would get, you know, kind of trickled down within the program. We obviously need those community pharmacists to do this and, you know, value what they're going to do. So I don't think that's even a concern that we need to be worried about.
The enhanced MTM pharmacists, all 400 of those community pharmacists do not pay for MedWise.
Yeah.
They get paid for conducting med safety reviews.
And the great news, if you were, you know, kind of talking to somebody about this in the elevator, is this is a better version of MTM, and it pays the pharmacist more, and it actually solves problems and reduces a major problem. Is kind of an easy way to describe it, maybe to a non-pharmacist. I know, Mindy, there was a slide about outcomes you wanted to show, and then Fatima, Ron, and I'm sorry I didn't catch your name, ma'am, from KIPA. Did that answer your question on everything?
Rosemary, he was asking.
Rosemary, I'm so sorry about that.
Yeah.
I squiggled on the thing here to try to get the name
That's
off
all
of
right.
it, and it didn't come up. But nice
Yeah.
to meet you, Rosemary.
Nice to meet you, Eugene. I guess the only other thing I just wanted to make sure on the $199 a month, but there also is as a prescribed wellness fee. Isn't that correct? To be with prescribed wellness, and this would be an add-on to that fee? Or
Yeah,
would that-
let's say we had a
could
pharmacy.
We could structure the program currently like it is today with enhanced MTM though.
Yeah.
It's a separate, it's our legacy access. So you literally get an account, you log on to MedWise through a URL, and all of the information is populated, which would have all of your assigned Medicaid patients in there. That's what they do today for the assigned Medicare Part D program for the enhanced MTM. So it would just depend on how we design it to make it what's the best way to give access. But that's kind of the cleanest way that allows that the 400 community pharmacists in those 7 states currently use today. And that's, it's we would love to have integrations into health pharmacy management systems today, but that's a technology feat that will take a few years for us to go down that road, starting with Pioneer.
Yeah, the goal of this program is to, help the patients in the great state of Kentucky, to reduce adverse drug events, to empower the pharmacists to help with those decisions. It's not to try to sell more prescribed wellness licenses. I mean, that'd be great, if folks wanted to sign up for prescribed wellness to be able to, do different things, but that's not the goal of this. And as Mindy just said, the program is fully operational. If the person says, hey, you know what, I don't want to use prescribed wellness at all, I've got another tool that I like, they can use it. To give it a real world example, if they like iPhones, they can use their iPhone. If they like Androids, they can use their Android. Does that kind of?
Yes. Yes.
Yeah.
Thank you.
I would do the Kentucky Louisville thing, but I know that would really kind of get everybody fired up. So we don't want to go that route.
All right.
Eugene, this is Matt Carrico. I have a question.
Yeah.
I'll just do the question, then I'll follow up with my concern so you'll kind of know where it's coming from. Who will have access to the patients? Like it might have changed with the new Medicaid that we've kind of started this month, but previously I've had out of state pharmacies call to try to get my Medicaid patients to switch to their mail order, and the patients don't know how they got their information. We don't know how they got their information. So my concern is pharmacies or mail order pharmacies or people that have nothing to really do with my patients will be calling, trying to do some of these MTMs and basically snaking them from us. And I mean, if we're the primary pharmacy, we should kind of know what's going on. So who will have access to it? Well, if only they filled the prescription with you, will someone have access to this to do it for them, or how does that work?
Yeah, I'll let Mindy, and I don't know if Brian's been able to join, go with the more technical side of this answer, but to give you the first part of it, that is not what's going on in the MTM. That's not what we're going to do in New Jersey. The goal is to keep the patient in the pharmacy that they are in, because obviously you're providing that care. And as far as the call center side of it is more of a backup, right? Say the pharmacy just couldn't, meet that need. Our hope is that it would be done at the pharmacy level, but the call center is more of a backup. And then the call center, as we've talked about, I know Ben and I have talked about this, and Mindy and Ben and I have talked about this, that we could use something that, potentially was Kentucky based if the program was big enough, or we could look down that side of things, or use some specific Kentucky pharmacists. But this is not the kind of program where we're trying to move people out of pharmacies. If anything, we're trying to keep them with their specific pharmacy. I mean, to use the example of Ron, we would want Ron to give his patients, this Medicare or MedWise advice, and then go over what they need to be doing to reduce their risk. And then we would want that patient to come back to that pharmacist. I mean, ultimately that would be the goal. And we would want the call center to work seamlessly to back up Ron or whatever pharmacist that was. So Mindy, that kind of gives the 30,000 foot view. Can you give the more technical side, or even add to the 30,000 foot view? But
yeah, well, I think the simple answer is we would structure it so that doesn't happen, one. Yeah. And two, coordinate any, let's say we could even set it up so that if you're not able, or your pharmacist on staff, for whatever reason, can't provide the med safety review, and you could do a referral to your colleague down the street, who can, right? We could set up a way to do referrals with each other, communications back and forth, so it's all coming through you who has the relationship with that patient.
Okay,
Ron, can I ask a question? This is Charlie.
Yes.
Y'all have implemented this in other state Medicaid programs, correct? Is that what you said?
New Jersey state legislation just passed legislation that was signed by the governor on July 2nd. So that will be the first formal state Medicaid program. We do have medication safety review programs with Medicaid managed care organizations directly with the health plan. We have a couple of those programs currently, but this New Jersey will be the first formal Medicaid program leveraging the community pharmacists using MedWise.
So I guess my question then was, do you know, does CMS provide the FMAP for states that implement your program?
What was the question? Will they provide, I'm sorry, will CMS provide what?
Will CMS provide the FMAP for this program? If a state,
That's a great question. We would work with the state on target patients. And like I said, you know, the question is, would we want to include the dual eligibles or not because of federal dollar funding, how that's attributed, et cetera. We would have to get into those details with the agency.
And has yours increased? I know a lot of states with COVID that has increased. I don't know if, I mean, obviously that has to be earmarked for specific areas, but just out of curiosity.
I'm just referring to the regular FMAP that we receive from CMS to operate the Medicaid program.
Right. I think that ultimately this is going to come down to your Medicaid making a decision of, you know, where this fits in and seeing how much, you know, we can reduce costs. And then obviously we will work with CMS. But as Mindy said, you know, we did have that legislation passed in New Jersey, and we could share that with you. It's in this slide deck. And on top of that, you know, CMS is very familiar with our program. They chose us to do the enhanced MTM model. But you do ask a good question.
Okay, and then my only other question is, will you send me this presentation so that we can have it for the open records? It's Charlie J.
Yes,
Hughes.
Okay. Yeah, we'll definitely follow up with that.
Thank you.
Okay. This 20-minute allotment has gone into an hour. And we still have other things on the agenda. So are there further questions from the committee members? And if not, do I hear a motion to have this presented at the MAC meeting for consideration of CMS on this program?
Ron, I might just say before we have a motion, I think we really need to have more discussion with the Medicaid department. You know, we've been working very closely with them on Senate Bill 50. You know, we all know we're just a month into that. And I think we really need to, work with, I don't know if, with Fatima and with Veronica and Commissioner Lee to see really, their interest in something like this before I think we should recommend it. That's just my opinion.
Ron, this is Charlie, I'm sorry, but I don't think this presentation is something that would be presented to the MAC. And then if you all wanted to make a recommendation that we look into this program, you may make that recommendation, but the MAC typically doesn't have outside presentations made at the MAC.
Okay.
Hi, this is Dr. Terrio. I was also, I'm trying to sit here and see how things would fit together. And I'm not sure how it would fit together in our current system without going through the MCOs. I can visualize this going to each individual MCO, but not necessarily through Medicaid to the MCOs. And I could be wrong, I could just not be thinking of something properly. But I think it would be a difficult fit in the current system.
What might be
you could
helpful
definitely
is,
structure that way, and depending on what your fee-for-service target patients are, or if you want to run it through the MCOs, that's absolutely another way you could run the program.
Well, I mean, I couldn't disagree more there because you've got, when you're talking about claim adjudication and that, when you're talking about the MCOs, that's all fine and dandy. This is clinical work done by the pharmacist. This is the pharmacist using what they went to school for, actually trying to practice at the height of their license to be able to utilize something that can save the state money. If the state is not interested in saving money, then that's another thing. But you can easily set up a network and by the cost savings of this program can easily be set up. Reason why I'm so for this, I'm for the expansion of the practice of pharmacists, period. And when you can use your clinical knowledge to benefit patients, I'm all for it 100% all the time. I think this program, has been shown to be beneficial elsewhere, and we just don't need the stamp of approval or anything else for by MCOs. We've operated the majority of Medicaid for all these years before the MCOs came along, and we can do so outside of that realm, especially when you're not talking about adjudicating a claim for lisinopril. You're actually having clinical interventions with patients, just like you pay doctors on the medical side, you pay nurse practitioners on the medical side for interventions with patients.
Ron, this is Meredith. I mean, I'm all in agreement with you that I think, pharmacists need to be reimbursed for the knowledge that they bring. But I do have a lot of questions and kind of trying to wrap my mind around how this does work and, how it does. I mean, in theory, it saves money, but it is going to cost. And I just think there's not anybody doing it currently. I don't think we have anything to base this on. And I think there's just still a lot more questions than answers at this point.
And just to kind of throw this out there, and again, we'd be happy to share the New Jersey legislature, and we'd be happy to show you EMTM documents as well. But I mean, honestly, the polypharmacy rise in this country has created such an issue with adverse drug events that this is, as to Ron's point, this is a real issue. And you have pharmacists in your state that can address this. What we would like to do is work with Medicaid and the stakeholders, on this call to try to work towards that. But we know we have the technology, we know we have great pharmacists in the state, and we know that there's a real issue out there that we really need to do something about because we've got patients that are having an issue with this every day. And unfortunately, there's not really another tool out there to do it. That's why it's an issue. That's why it continues to be an issue. That's why close to 200,000 people died from this last year. So I hate to bring doom and gloom, but the good news is you have some great folks in Kentucky. We'll guarantee the savings, and we have a great opportunity to kind of put something together. We'd love to obviously talk with the stakeholders on this call and others within the state to bring this to fruition, but we have an opportunity to make a difference for the folks in Kentucky.
This is Charlotte again. If you want to send me your presentation, and I will make sure of course, Fatima is on here as our medical director and our pharmacy director, and we've got our medical director, and I will be sure we forward the presentation as well to our commissioner and our deputy commissioner. There's procurement laws that we have to go through in order to implement anything. So if you provide your emails, all your contact information, and if the commissioner or deputy commissioner have questions, I'll have them reach out to you all.
Yeah, and then we're happy to do one-on-one phone calls with folks to go over this, or if there's another group that'd like to come together, whatever, Chairman Poole you'd like us to do, we're happy to do that, or others.
Well, again, Charlie's not the chair here, so what is the action of the committee? You want to table this, or what do you want to do?
And I know I'm not the chair, Ron. I was just trying to get his presentation to the higher ups in Medicaid that could help to get this program going if it's something we wish to implement.
Right.
I make a motion that we table this for a later time and address some of the other issues that we're having right now.
Seconded.
Okay. Motion by Meredith, second by Rosemary. Any further discussion? All in favor say aye.
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 Any opposed? Thanks, Eugene. Thanks, Mindy. Appreciate it. And we'll be in touch, okay?
Absolutely. We're
Thank
standing
you
by,
very much. We appreciate it.
and we'll get the presentation over and then we'll go from there.
Okay, thank you.
Thanks for your time.
Thank you.
Charlie, if you could please put the agenda back up there. Okay, on the performance evaluation of Med Impact, on the payment frequency, issues that pharmacy owners and pharmacists are in a financial or cash flow crisis right now due to the lack of payment. Does anybody from Medicaid have any comments to tell us what's going on in speaking with Med Impact on these issues?
Yes, Ron. So we have a meeting with Med Impact this afternoon to discuss the solutions around the payment frequency. One thing I'll mention is that we hear you loud and clear, and we're actively working to help come to a solution that's amenable for all.
And I'll just add something else here. When we've had a lack of action by our legislators, both state and federal, on what's happened to the pharmacy industry, where we have clawback fees in the $500,000 range, and we have a lot of things working against us. It's not an industry anymore where you have much cash flow. You're working and rubbing two nickels together to try to make sure you can pay the next several $100,000 payment to your wholesaler. So this is the sign of the times, and it's been created, whether it's the Federal Trade Commission's lack of tolerance in allowing monopolies to be formed, whether it's ratcheting down of reimbursement below our cost or what have you, but this is the new reality. Does anybody have any other comments on the payment frequency issue?
Fatima, this is Meredith. So if you all have a meeting this afternoon, I mean, how quickly do you expect to get information out to us as far as what the solution to the problem is and how quickly you can implement the change?
I provide updates to folks like Rosemary and Benjamin all the time. So, we will certainly provide updates after our meeting, but there are some factors that will play into this, such as, MCO dependency, Med Impact from a system perspective, and, from a financial perspective as well. And ensuring that all the parties are aligned. So we will provide updates as we have them. I can provide one right after we meet, and let you know what was the outcome of the meeting.
Okay, we would greatly appreciate that.
So can they provide that to the rest of this group? If you get it, Ron or Rosemary, you'll provide that information to the rest of the PTAC committee?
Yes, ma'am.
Thank you.
Ron, I just want to add to my amen to what you said. We're all in that same boat. And, I think Fatima and I have been talking, and, we're all looking forward to a solution, because we have pharmacies across the state in really a dire situation right now.
Right. Okay, Matt, if you want to comment on the next one, the prior authorizations for, I guess, either the grandfathered medication changes, or you want to speak to that?
Sure. I can't speak for firsthand knowledge, but I've had a couple pharmacies call me since they know I'm on the TAC, I think they think we know a lot more than we do. But they were raising concerns about trying to get PAs for stuff that's grandfathered that they know is going to stop being on formulary by October 1st. One person mentioned a patient that was on some drug that's thousands of dollars and it's due around the 1st of every month, and they're not able to start doing PAs on it yet. They were telling me. So I'm trying to just follow up and see if that really is the case, if people aren't able to start working on PAs now to make sure these things are covered on October 1st and that Medicaid Med Impact doesn't just get an avalanche of PA requests at the beginning of October and patients are waiting without medicine. And I just want to kind of see if that's true, what kind of, or if it's not, what can I tell them? That was mainly it.
Matt, this is Fatima. In terms of prior authorizations, if you all want to submit them proactively in advance, you are more than welcome to do that. If you can provide a little more specific information as to where you heard what you had just mentioned, we can help mitigate that.
So Fatima, this is Paula. So are you saying that, because I just had this question today from another pharmacy, if they submitted something today, and the transition period ends September 29th, that PA could go into effect for this member on, September 29th or September 30th. So they could, okay. All right, I'll let them know. Thank you.
To back up, I've got a chat question here. Fatima, if you could provide the correct phone number for Med Impact payment issues, the number given has been disconnected.
I will defer that to Med Impact. They're present on this call. Don't have that off the top of my head right now.
Yeah, and Fatima, I don't either, but I will follow up with you immediately after the call.
And who is this speaking?
I'm sorry, this is Rob Coppola.
How you spell your last name, Rob?
I'm sorry, it's Coppola.
Okay, if you can provide it to me or Charlie, and she'll get it out to the rest of us. If I get it, I'll send it out to the PTAC members, but we need to get this out to everyone.
Will do, thank you.
Okay, I just put this on here for formulary coverage or continuances of therapy. Obviously, we had a continuance of therapy, especially for basically anything that's psychiatric. I just want to make sure that as far as I can tell that those things have been honored. Is anybody having any trouble with those medications? Okay, not hearing anything, then we'll go on to the next topic. I do know that Fatima, instead of me explaining this whole thing, it is Medicare guidelines to pay administration fee for the second dose of COVID vaccines. So what is being done to alert or maybe Rob Coppola could talk on this about getting the second administration fee put in place for COVID vaccines?
Yeah, so Ron, we recognize this issue and we are well aware of it. I apologize, I was at a conference the past few days. So Robin, Seeley, and Rob, who are on this call, I don't know if you have any updates from the last time we had emailed about this, but we are aware of this and there is a fix that is going into place on the system end.
Okay. Rob, do you have any other further information for us?
This is Robin Seeley with Med Impact. I've been working to ensure that patients who are in the lock-in program are able to receive COVID vaccines no matter where they go. But I will certainly look into this second dose administration fee. This is the first I've heard about it.
Yeah, all of my pharmacists have let me know that on the second administrative fee that 0 is paid. And, every other third party we deal with, whether commercial, Part D, what Medicare themselves is paying the $40 admin fee.
Right, that's a different issue than the one I've been working on, so we'll look into this. Thank you.
All right, thank you.
Hey, Ron, there was somebody in the chat box. I hate to go back to this is Paul again. I hate to go back to the PAs, but it looks like someone added in the chat that to add some information to the PAs not being submitted early. I am a pharmacist at a primary care office group, and we have been unable to submit early due to issues with the MedImpact website. The links to the PA criteria were not working until this morning, so our offices had no idea what to submit. So maybe we need some clarification on the early proactive PA process.
Fatima, could you check into that? Because apparently that is an issue of people trying to proactively work on the prior authorizations.
Okay, so I see here issues with the MedImpact website. The links to the criteria are not working. Okay, yeah, let me take that back to the website developer, and Rob, if you can assist with that, that'd be great.
Do, Fatima. And we do have folks from a quality assurance perspective that always check on this. So this is the first we've heard that they're not working. And I saw the chat. I did validate they are working now. So, but we're going to look into it. Thank you.
Okay. And obviously, the means that you all use to get the word out to everybody, please do so. So, if we try to send it out through all of our connections, that's fine, but there's still going to be gaps there. So certainly all your network pharmacies would be nice to send those out to everybody.
Ron, I did want to jump in on the COVID vaccine fees regarding the second dose. Monday night, I got an email that the pharmacy that had initially reached out about the COVID vaccine fees was able to get the correct reimbursement. So I'd encourage the pharmacies to double check that and reach out if there are still issues on that end.
Okay. And just call MedImpact to see what codes to use. That is probably a code issue.
Yeah, you all can certainly call MedImpact, but if the fees are not coming in with the appropriate codes and processing information, then certainly reach out to myself and I can help triage that.
Okay.
Hi, Fatima. This is Chris from MedImpact. I just want to note that the fix has been implemented and backdated, and if there are pharmacies who have outstanding claims without admin fees, they can certainly resubmit those, and they should be reimbursed appropriately for the admin fees on those COVID claims.
Okay, thank you, Chris.
And Chris, again, could you send out a note to all of your network pharmacies to let them know that, please?
Yes. Yeah, we can certainly send some fax blast out to the pharmacies. That's absolutely.
Okay. Thank you. The only other topic here was I was wanting some input from sterile and non-sterile compounders along with specialty pharmacy pharmacies in the state who deal with specialty pharmacy as to what would be a suggested starting formulary. I've got my own list started with non-sterile, but basically I know the UK Med Center does a great deal of compounding that does not get reimbursed, that saves them money in the long run, but it's a better treatment for the patient, but they're not getting, it's a cheaper therapy, but they're still not getting reimbursed for it. So anyway, I just would appreciate anybody passing the word along. I know a few specialty pharmacies and certainly know quite a bit of sterile and non-sterile compounders, but I just was hoping to get a good amount of people weighing in on what would be a good starting formulary, because this is something we're trying to work with Commissioner Lee and Fatima on over the next 6 months to get something established on both. Okay. So I just need everybody's input on that.
Hey Ron, this is Philip. I can reach out to a lot of the other health systems as well as like Dan Grants and his team.
Yes.
Try to get like just a consensus dumping of really all those items so we can.
That would be
at least
great.
Starting list there.
Yeah, he was on that little ad hoc committee that I had to work on, the suggested reimbursement where we came up with the SBAR report. But no, that would be great, because he's definitely got the knowledge base to know what's being done and what kind of cost and what are the more routine things that they could suggest. So yes, that would be great.
I think I'm going to say it out loud. I think so, and I don't know which pharmacies participate in this or not, but it's starting to emerge in the industry of pharmacogenomics, where even in some independent pharmacies, and we haven't done it at UK, where there's the ability for the pharmacist to be involved in that testing level and interpreting the pharmacogenomics, and then making recommendations to the provider on non-standard dosage forms. So this I think is something that Kentucky needs to think about regardless, because this is eventually coming, I think.
And it seems to me, Phil, you tell me if this is wrong or right. It seems to me that it is weighing in heavily right now on psychiatric medications because it seems to be that's where the biggest development has been with pharmacogenomics and the most helpful. So people aren't, not only having the alternative dosage forms and alternative medicines options, but to be able to pinpoint somebody's ideal medication. So it's not going to waste time in getting them regulated and waste money of the payers. So I definitely agree with you 100% on looking at that pharmacogenomics.
I think behavioral health is a big piece. We're also looking at the oncology space. And then I think it depends on, so we have actually toured 3 different platforms, at least UK has, and trying to see if there's a good one to partner with. But we're kind of picky here. We want one where the pharmacist is involved as sort of the quarterback, communicating with the provider, explaining the report to the patient, and then offering solutions. So I think that's going to be big. And, I think, but going back to just the compounding, I think pharmacogenomics is a big piece. I think hormone replacement therapy, palatability for, and I got 4 kids and none of them ever took azithromycin liquid. They always spit it up. There's so many opportunities for the pharmacist to improve care through compounding solutions. I just think we should reimburse appropriately. The same thing with specialty.
Okay. That's good comments there. But anyway, I just need everybody's help in chiming in on that. Anybody who wants to reach out to people who are in any of those arenas, please give them my email and have them contact me so I can get their input. Okay. And Ben, Mudd, if you're still on here, I could use your contacts to reach out to a broader base also. Okay. We're at the end of our agenda. Do I hear a motion to adjourn?
So moved.
So moved by Matt.
Second by Rosemary.
Second by Rosemary. Any further discussion? All those in favor say aye.
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 Any opposed? Thank you all very much. Have a great afternoon.
Thank you.